It is a huge honor today. I just got done lecturing all day in Singapore, and Dr. Jonathan E. was there today. And Jonathan, when I think of Singapore, I only think of you because you have, 3,663 posts on Dental Town.
About there if I haven't posted in the last minute.
Thank you so much for sharing 3,663 posts on Dental Town. I just feel like I know you. I feel like you're a brother, a cousin, a nephew, or whatever. So I'm sure a lot of Townies, after reading your post, are so happy to meet you because on your avatar, it's a picture of you with your loops on and your mask. So when I met you today, I couldn't have picked you out of a police lineup.
Oh, yeah, that's like my superhero identity, see? So, yeah, I'm shy. Yeah.
Are you shy? You don't seem like you'd be shy at all. So you got out of dental school in 2007.
2007.
And when did you become a Townie?
I think it was actually 2010. I was looking at my profile just now. 2010.
So 3 years out of school.
3 years out of school.
And how was and what is Dental Town meant to you, or what do you think of Dental Town?
Dental Town, I would actually credit most of my professional development with Dental Town. If I really look at it, it's the way that it works in Singapore is that we graduate with a government bond. So when we do our school, we do school for 4 years, and the government subsidizes that, and we have to work for another 4 years for the government, right? So it was at that point I was about 3 years in, happened to be randomly surfing about dental stuff, and then, Dental Town. So I joined it, and then it opened up a lot of different viewpoints, a lot of different ways to do things, a lot of different ways to look at things, and just by reading bit by bit and seeing what, everybody else was doing, it starts to give you new ways to do things, new ways to look at things, new ways to do things better.
So when you're on Dental Town, so you're over here in Southeast Asia, you're in Singapore. I notice a lot of dentists that I met here, that usually they went to dental school either in Singapore or Australia. Is that a fair reflection?
Yeah, it's a pretty fair reflection because our faculty here is pretty small. They've been expanding it from my time. My time we took in 34 people, and now it's about 60. They're intending to expand it to about 80 in the next couple of years.
The dental school graduating class?
Yeah. So of course, with only 30 plus people coming out in my time, there were people who couldn't get in, so they'd go over to Australia, and they'll do the time over there, and then they'll come back.
So when you're on Dental Town, does the flavor to you seem like Dental Town, does the flavor seem like it's more international, or does the flavor feel like it's more just Americans?
That's like, I don't know, if I could describe it as like, it's like a roast chicken with barbecue sauce on it, So dentistry is the roast chicken. No matter how you roast the chicken, it's still going to be a roast chicken. But the sauce that you put on it gives it a little subtle flavor. So it still has those American roots, but there are so many international clinicians, some of them from places like the UK, some of them from Iran, some of them from South America, and they put different spins on it too, but at the end of the day, it's still teeth. So there are going to be some things with local context on it, like, insurance, billing codes, the way that you approach advertising, but the teeth itself, that's pretty international.
So, I think a lot of American dentists would be highly jealous of you, because if I asked Americans, list the top 5 things they hate the most, I think dealing with insurance companies would make the top 3 probably of every dentist who voted, and you don't have dental insurance in Singapore.
It's very much less, all right? The way that it usually works over here is that maybe the company will say, okay, every employee you get $150 a year, and you guys can spend it on dental whatever way you want. You just show us the receipts. So it's not less of a situation whereby they're saying, okay, we have to buy a plan with this company, and then this company is going to give us this much, but then the dentist has to be signed up with the company separately, and then they have to do it according to a certain fee schedule. So there's a lot less of the layers of administration to go through.
So I'm not aware really of dental insurance being a factor in the countries of China, Philippines, Taiwan, Hong Kong, Malaysia, Cambodia, Vietnam, Indonesia, Singapore. Is that true?
I would say, yeah, pretty much. In fact, a lot of the times when they're bringing in insurance forms, it's either they're expatriate or they're working for a multinational corporation.
Yeah.
Yeah.
Because so dental insurance is a factor in Australia and Japan,
Yeah.
but not anywhere really else in Southeast Asia.
Very little.
Or Asia in general. Would you say Southeast Asia or just Asia?
Possibly Asia, though I don't have a good look into like the China region.
Yeah, I'm not aware of any insurance in China.
Mm.
So the reason I bring that up is that I believe so many Americans believe that they have to participate in these plans. They have to be insurance driven. When you tell them, dude, there's 2 million dentists around the world, and only 200,000 of them deal with this stuff. I mean, they don't deal with this in Brazil, Asia, Latin America. I mean, it's just a non-issue, and you have to just get people to pay out of their pocket for your services. And I think that's a great mental exercise for all the dentists in the UK and Germany and Australia and New Zealand and Canada and America that just believe that it's all insurance driven.
That definitely is an issue. I see so many dentists on Dentaltown grappling with that because the public has been led to feel that way about it. And I can't remember who it was. It's just such a thing that everybody says, you never get tire insurance, but you need to change your tires, every so often, but, you never get gas insurance, but you get dental insurance on something that you're going to need for like frequent and periodic regular care.
Yeah, it is very bizarre. So what other, sitting in the middle of, sitting out here in Southeast Asia, between China, Japan, Australia, America, all these countries, you probably are a great referee point to seeing variances. Like I noticed like one variance on clinical dentistry, like Australians buy more glass ionomer than Americans do.
That's because they practically invented the stuff.
So talk about that. Why is that? I like to go over the variances, and that's a huge variance. What's the story behind that?
I think it's probably because that's the way that they're educated. They're practically brought up in this stuff because there's a clinician, Mount. I forget his first name, but he did a lot of he basically developed glass ionomers, and he's an Australian. So, from
what was his name?
Mount, Mount.
Mount.
Yeah, Mount. And he...
Is it Mount Kosciuszko? Or
no, that's his surname. Yeah,
No,
not Rushmore, but yeah. So he basically developed a lot of the glass ionomer technology, and he had a lot of clinical experience with it, and so he loves the stuff. And because he teaches, so all the schools are influenced by it. It's just like how, on the other hand, if you flip it around and you look at America, the knowledge base on composites is a lot stronger than glass ionomer. I still get people asking if, should you bond before you put in a Fuji? The answer is no.
And talk about that. Why? Explain it. If you get that question, I think go over the question. Explain it in detail. Because if it's a frequent question, a lot of podcast listeners might have it too.
Okay, guys. Glass ionomer, right? It's a hydrogel. It works by an acid-base reaction. So you take the liquid, all right, polyalkanoic acid, and you mix it with the fluoroaluminosilicate glass. All right, these two combine together and they form a jelly substance. The beauty of the glass ionomer is that when it is brought in contact with the tooth structure, it starts to take the metal ions out of the tooth, starts to take the calcium out, and mixes it with the filling itself. That's the power of the bond. So if you go and put a bonding agent in there before you lay down the glass ionomer, it's passive. It doesn't form that layer of ion exchange, and you might as well have put an amalgam in it. It's about the same.
Wow, you're very knowledgeable in that.
I had good teachers.
So do you use glass ionomer?
Yes, I do. It's got its places. It's got places where it works better. It's got places where it doesn't work so well. Of course, if you're putting it in a cavity where it's not loaded, it's going to do beautifully.
What do you mean not loaded?
Perhaps like an upper 8 occlusal, or the buccal of an upper occlusal where you're not going to have an occlusal load on it. But the area that I find at this present point in time it's not doing so well would be the class 2s. Those areas there, because of the marginal ridges, they take all the stresses. I have personally been finding on the cases that either I see in my clinic that they come back maybe in about 3 years' time. The marginal ridge is chipped, and then you start to get fluid impaction. The second problem is because this stuff works by acid-base reaction. So if you got that food in there and all the bacteria in there, and they're creating an acid environment, it makes the glass ionomer start to wash out faster. So from what I've seen from the products in Singapore, Class 2's no good. However, GC has come out with the Equia. I haven't had a chance to play with that yet. They're saying it's strong enough to run in the Class 2s. And I'm also seeing Activa coming out. That one, it looks promising as well. I'm not entirely familiar on the chemistry, but it looks like it's going to be like an RMGIC on steroids.
Are they going to call it the Arnold Schwarzenegger since it's on steroids?
Pretty much. Yeah.
What about other restoration? Is gold very common? Like, I have 7 restorations in my mouth. They're all gold inlays and onlays because I'm old school. I believe gold lasts the longest. Is gold a factor in Singapore?
Gold, there are people still doing gold. I used to offer it, but because my clinic is more aimed at a slightly more budget patient base, so I've actually switched to a non-precious metal alloy. Yeah, so that, it's not as pretty. It's not burnishable, which I dearly miss, but yeah, it's tough as heck. So I can give the patient a long-lasting, durable restoration. And if it's for an upper molar, they're never going to see it. I put one in my mother. No one's seen it. No one said anything nasty.
So how old are you?
I'm 34 in a couple months.
34, and you got out in 2007.
Yeah.
So, what has got you excited? I mean, you've been doing this for going almost a decade now, and you're in your youthful prime energy. What's got you excited about dentistry? What are you looking forward to do in the next decade?
All of it, man. There's always going to be advances. There's always going to be things that work out. There's always going to be things that you thought would work out, didn't work out. But that's just part of the challenge, you know. You get to see things like, you know, the developments in implant technology. You start to develop new materials for crowns. The other day, I got this news over Facebook that suddenly Sirona's just gone and done something crazy, and they've invented a way to process, meaning, you know, from start to finish, the lab end of a zirconia single crown in slightly less than an hour. Which means that now, you know, even for a slow guy like me, if I bought the stuff, I might be able to make a zirconia crown for a patient using the CEREC system and have him out the door in 2 hours. And in, you know, just within the space of a few years, we've gone from, 5-hour sintering times into something that can do this. That's big.
So, do you have a CEREC machine?
I have access to a CEREC machine.
And what does that mean?
Oh, basically for me, I work in 2 locations. I work a little clinic in the suburbs 4 days a week, and then 2 days a week I work in a bigger clinic. It's another clinic in the chain that I work in, and they have a CEREC machine in the weekend.
Yeah. Have you been playing with it?
Blue Cam.
And you've been playing with it?
Yep.
Do you like it?
I have a love-hate relationship with powder, so.
Yeah.
Yeah.
What other things are you thinking about? Implants.
Implants, I'm not thinking about it. I'm doing them.
And tell us about that part of your journey.
That's also part of a journey linked to Dentaltown. It's just interesting how all these people, you know, from various different diverse backgrounds influence you. My big influence in Dentaltown is a dentist by the name of Bill Schaefer.
From London.
Yes, Bill.
Oh, I love Bill.
Yeah, mentally I have him pegged as Bicon Bill because, you know, he was this guy who came on in Dentaltown and he was showing off all these implants, and, you know, it's like, hey, where's the other half of the implant? Has it just been chopped off or something? They're 6 mm long, and then, you know, everyone was saying, he's crazy, it's never going to work. And he said, yeah, but it does, and here's all the recalls. And he would show case after case after case after case after case.
And they still don't believe it.
They're swinging around. That's the beauty of Dentaltown, you see, because they have a community consensus, you see. They, as a whole, you know, by just every so often locking horns on a case, you know, they'll come to an agreement, okay, this pretty much generally works. And I did see a shift in the consensus from, oh, you need an implant like 20 mm long, you got to anchor it in, you know, the base of the brain, you know, and Bill started showing off all these, 6 mm, 6 mm, 6 mm. And he's also not an extremist in the sense that he'll do shorties when he needs them. He'll do longies when he needs them, you know, and but he just showed, these are the cases where you can do them and they're going to work. And these are cases where you might not want to choose them. You don't need to do it the way that I do it, but you can look at how I do it. And, if you want to give it a shot, why not? And I saw this consensus shift. So he was a big influence. He got me onto Bicon implants pretty early on, right? So
Bicon out of Boston.
Bicon out of Boston. Yep, the little Boston miracles. So I actually philosophically am a Bicon guy at heart.
Is that what he places now, Bicon?
He does Bicon Ankylos. I think for certain reasons he's moved a little bit more towards Ankylos.
And Ankylos, is that by Dentsply?
Yeah, they bought the product. It's a German design. It's got a good long history on it. I think 85 or 86.
But that is Dentsply, right?
Dentsply, yeah.
And that's their first really top-line implant system. I mean, they've had a few systems over the years, but
Ankylos, that stuff's built like a German tank. Yeah. For me, however,
Is it made in Germany, you said?
Made in, I'm not sure, but the designer's German. Yeah.
The design is German?
Yeah. I use Megagen, though.
Yeah.
Yeah. They've got a lot of very similar design principles to Ankylos. Good, solid, conical connection. Just good common sense design on the prosthetic parts. So it's nice to put in. It's nice to restore. They've taken a lot of the principles that made the other implant systems like Ankylos and Bicon and Astra successful, and they've incorporated it into their own designs.
And didn't a third of Megagen just get picked up by Straumann?
Big chunk, yeah. Straumann put
Was
in
it
a
a
lot.
third?
I'm not sure about the raw numbers, but there was a hefty chunk of money that they invested into.
And
Megagen.
Straumann's out of Switzerland or Sweden?
Yeah, Switzerland.
Switzerland?
Yeah.
So I want to ask you a question about you and Bill. When I talk, the most common email I get in my inbox at howard@dentaltown.com, an email, the most common email is always the same thing. It's a link to a thread, and they tell me, you should get on there, and you should say this, or you should post this, or you should say this, and you say this. And I'm just sitting there like, why the hell should I say it? These are your words. Why don't you say it? And you look at the data on Dental Town, I mean, 9 out of 10 people just lurk. They just lurk. They lurk. And here's Bill that can post a case going back years and years and years where people are saying, you're crazy, this is too short, this will never work. Talk to me in a year when this fails. And why is it that some people like you and Bill can post thousands of times, yet 90% of the human condition of a dentist is, I'm just shy, I just lurk? What advice could you tell them? I mean, how many times did you post? I mean, why can you psychologically post? Why can Bill post something that is controversial, short implants, and 9 out of 10 dentists on Dental Town just cannot pull the trigger and post?
Sometimes you just have to take the first step. How would I put it? Nothing ventured, nothing gained. It's kind of it's kind of like when a patient's not quite sure if they should do something, and I always tell them, I believe there's the UK Special Air Service have a saying, "Who dares wins." I also heard that I think it's the Navy SEALs. They have a saying, "Pain is temporary, chicks dig scars, glory is forever." So sometimes you have to take the first step.
Chicks dig scars.
Glory is forever.
That is a funny thing. I always said, I have sisters and friends, stretch marks from babies. I said, man, if men got a stretch mark from having a baby, they would show everybody. You could not meet a man, and within 5 minutes, they'll show you their scar, their knife, their bullet wound. I said, only a woman would be embarrassed of a stretch mark scar from a baby. I mean, when men get the stretch marks on their shoulder areas from lifting weights and building their pecs too fast, oh, they love those scars. They show everybody those scars, but that's a great thing. But yeah, it's just. Do you think they do it because they're thin-skinned, or do you think they're afraid, or
I think they might be a bit afraid. I mean, sometimes it takes a certain something to stand up and say, "Hey, I've got a different opinion," because everybody wants to be loved. It's just like the same thing when you need to break bad news to people. Sometimes, like, your mouth has problems. We need to sit down and talk about this. Sometimes you just have to take a deep breath and do it.
So go back to implant systems, because my whole motto with Dental Town is that with Dental Town, no one should ever have to practice solo again.
Yeah.
And when you walk into the Cologne has the meeting every other year, last cologne meeting, 175 different implant systems.
Ooh.
So here's someone listening to you alone. They see all these systems. Why did you go Megagen? How could you help them pick a system?
Okay, Megagen was a bit interesting because just like Bicon, I actually knew the system by reputation before I even met a single sales rep. And why was that? Because of Dentaltown. We have we got a lot of users. Jerome Smith, I think, is a Bicon user. Some of the other guys who are hardcore strawmen have started moving towards Bicon, towards Megagen as well. Megagen, so they were already discussing things like, I'm finding that it's working very well in my hands in this and this and this way. We also had one particular poster. I haven't seen him on for a while now. Kang Tae-ho. He's a Korean dude, and he was an automotive engineer before he went to the U.S. and got his DDS. That's kind of a strange combo, But what he brought to the table was a really long, heavily illustrated thread on how implants work from a mechanical perspective. How you design those implants so that they're going to work, they're going to go in, they're not going to break, which are the good connections you need to look for, and Megagen ticked off all the boxes.
Yeah.
Yeah.
He had some very amazing illustrations, drawings of just things that you could just tell that I'm a dentist, I wasn't a mechanical engineer, and he explained it so eloquently.
He did, yeah. So, by the time the rep popped by, and that was Moon, by the way. So she popped by and said, "Hi, doctor, would you like to look at my brochure?" I said, "Megagen, where have you been all my life?" So that was great. And the other thing that helped me out with that, they've got a really good service culture. Yeah, I think Dr. Morgan from Bicon always jokes that if the reps in America heard about what the reps in Asia do for their customers, they would kind of freak out. Like, I think the culture over in the U.S. is you buy a whole box of implants, and you buy your own motor, and you buy your own stuff, and then you buy your bits and pieces, and then you bring all that inventory into there, and you just put it there, and then, okay, where's the patients? So the way that it works in Singapore is a little bit different. You can actually go to the supplier and they say, okay, this is an a la carte price for, one fixture. And, they will, if you're like a new user, they'll come down and they'll bring a motor for you. They'll bring the handpiece for you. They'll bring a whole suitcase full of fixtures so you can just pick the one that you want. And you do the surgery with them kind of like over your shoulder, and then you stick it in. And then, they'll just bill you for that one thing. And then after that, when you send the stuff off to the lab after the impression's been done, they'll hook up with the lab, and then they'll get the stuff, and then they'll send the invoice to you later. So I think that makes it a lot easier for a clinician who wants to just kind of get his feet wet in a system without having to commit to thousands of dollars of inventory, especially if you're not quite sure what kind of implants you're going to put. Are they going to be the long ones, the short ones, the fat ones, the thin ones? You don't know what are the sizes you're going to be putting in regularly, and you don't have the stock that's just going to sit there and expire because you bought like a 10 mm long, 8 mm wide implant. It's never going to be used.
So hit on the other controversial parts of implantology. Surgical guide, yes or no?
Well, I'm a bad boy. I do a lot of freehand. Yeah, in fact, I do all of them freehand. But honestly, what I'm finding is that when I have to do more than two, all right, that's when my placement starts to suffer a little bit. It's not enough to make it unrestorable, but it's enough for me to look at the x-ray and think, damn, that could have been better. So I think those are the places where the surgical guides...
For multiple units.
Yeah. That's when it
but
starts to become more...
But why do you say you're a bad boy? Because that's one of the reasons I keep hounding that question, because every single dentist I know personally who's placed over 5,000 implants, they never use a surgeon. They wouldn't even think of a surgeon. They'd say, be a real surgeon. Especially single tooth. When you got a tooth in front of it, a tooth behind it, you got the buccal plate lingo. They think it's comical. But so I like to go to where there's a lot of noise, where there's a big variance. So there's a lot of noise that you have to have a surgical guide. You got to make a surgical guide. You got to make a surgical guide. And then I've done 10 podcast interviews with 10 guys who have each done 10,000 implants who never use a surgical guide. But you're saying that for a single, it still makes sense to do it free-handed. But for
Totally.
multiples,
Yeah, it's the
starting to see how it would be
multiples.
better.
You know, those are the ones unless you've got really good eyes, because maybe I just have average eyes. You know, on the other hand, when you think about it, you know, you take say 30 minutes of doctor time to put in the first implant, but you take 5 minutes of doctor time to put in the second implant. You know, and when you're doing the impression, it takes maybe 40 extra seconds to screw on the coping, and it takes 40 extra seconds to screw off the coping. You know, maybe the issue stage might take about the same time if you're doing two, but that means that, you know, your profit versus your time for that second implant, which you placed at the same time, is not so bad, and you're probably more able to absorb a guide cost anyway. Of course, the other thing is, how good are your guides? You know, are you just like making a thermoplastic stent and okay, it's kind of in that neighborhood, let's bang it in there? Or are you going to do one of those foofy guides with, you know, the rings and, it fully restricts it and have to buy a guide kit as well? So, you know, long story short, Armin, come to Asia.
So tell them about Armin. So what's got you excited about Armin? How do you pronounce his last name? Minyanas?
Mirzayan?
Mirzayan?
Yeah.
Armin Mirzayan out of Southern California. What city is he in?
I'm not sure, man. I also only know him by internet reputation, but
Yeah,
Armin,
I love Armin.
He's kind of made it his mission in life to make dentists use guides for their surgery.
And what's his website? CAD
Ray.
But there's a hyphen in it, isn't it?
I think
CAD-ray.com.
But he probably bought up all the internet addresses, so they all just direct in.
Let's
Yeah.
just find out. You talk and I'll see what is.
Yeah. So Armin, his vision was to basically find ways to make guides more affordable to the dentist, and by reducing that cost, you increase the usership of guides, and that's also going to help dentists with reducing errors in terms of placement, you know, which once again reduces your issues in terms of restorations, which can sometimes cut costs rather than having to use, like custom abutments in a case where a stock abutment could be modified and used, you know. So there are definitely benefits to it. It's just that on our end over here, it is challenging, first of all, to get the logistics to get a good guide done.
Well, you're right. He did buy CAD Ray without a hyphen. So it's CAD-Ray, but he did buy CAD Ray because I just did CAD Ray and it redirected me to CAD-Ray. Okay, sorry to interrupt you, but yeah. So go to CAD-Ray. So continue about Armin. Sorry to interrupt.
Yeah, so he was finding ways to get these scans done. He was doing the legwork. He was trying to find ways in which, you know, he could take that patient either model or STL file and find ways to get that integrated with a cone beam so that he could figure out, okay, sinus is there, nerve is there, you know, where are we going to avoid it? He was trying to find ways to get this linked up with clinicians so that they could look over the thing rather than just a technician, you know, working over the models, and, you know, they could coordinate with the surgeon dentist. And he was trying to find ways to do this economically, which is a really good thing, you know.
Yeah. So you're not. So if you do a stent now, what are you doing?
Unfortunately, it's probably going to be something homemade. So I would probably be making thermoplastic and then, you know, filling it with resin and then drilling a hole through it with my pilot drill. Basically, a pilot guide. Yeah.
Yeah. So let's talk about. So we've talked about implants. We've talked about. You have access to CERAC on one of your offices. Is ortho on your horizon?
Ortho's on my horizon, yes.
Are you doing any of that, or what are your thoughts on ortho?
Ortho, actually, my first interest was in ortho was because of Rick DePaul.
Yeah.
Yep, Rick.
PowerProx 6 months ortho?
Rick, yeah.
Is that what it's called? PowerProx?
PowerProx, yeah.
PowerProx 6
so,
months?
I mean, the way that we were taught in school, honestly, there wasn't a lot of hard skills. There was a lot of diagnosis, you know, so it's okay, take the LETSF, take the OPG, examine the patient. He's class 3. Okay, let's move it to the postgrads. So, unfortunately, you know, this is an area that that our skills are lacking in. And, I mean, there are certain concerns about it, of course. You know, sometimes the stakes are a bit higher in ortho. You know, there are things that you can do in a case if you don't know what you're doing, and you can mess things up, and it can be difficult to treat. And, you know, we're not in the business of messing up young ladies' faces, you know. So, of course, there should be proper caution, proper diagnosis. But what I think Rick has done is he's found a way, all right, for us to first of all diagnose, all right, which are the cases that can be done simply. He's found a way to treatment plan them so that they can be done predictably. All right. He's even got marketing tips in there on how to deal with these cases. So what he's teaching through the PowerProx concepts, I wouldn't even call them a system. The PowerProx concepts is how to find cases whereby you can treat a patient in 6 months or less predictably and safely. All right, and then go ahead and do it.
So now you're saying PowerProx a lot, but the website is 6monthbraces.com, right?
Yeah,
And so you're doing that now?
I'm doing that now.
How long you been doing it?
Maybe close on to about 1.5, 2 years.
And so how did you initially learn? I know he has like a CD program, or he's got courses
I got it
on
from
Dentaltown,
the
or-
CD program.
You got the CD program?
Got the CD program.
So tell us about that. How many hours was that? How much money was that?
Man, that was 6 DVDs. It was long, but when you just bring a DVD to the office and then at lunchtime you just play one, and then you come back from work and then you play another one. So it goes by, and sometimes you just watch them again and again, come back to them in a couple of months. You'll pick up little things here and there. I mean, of course, a DVD series is not going to tell you everything, and he doesn't say that it's going to tell you everything as well, but I think what some people have said is that PowerProx is like a gateway drug to ortho. It's a way of introducing the style of thinking, because to us, sometimes tooth movement is a foreign thing. You look at that case and say, oh, I'll never be able to fix this up, and it just opens up options. Hey, that tooth over there is sticking out a little bit, and if we line that up nicely, it's going to be easier for you to brush, and that might take about 4 to 6 months,
So what is okay? So to these homies out there listening, the website's 6 month braces, but they're confused because they hear you saying PowerProx or 6 month braces. They hear other terms like Invisalign. They hear Inman aligners, like TIFF out of London. So what's the other one? 6 month smiles.
6 month smiles. Who's that?
What's the
now?
one Ryan Swain started?
Yeah, that's Ryan. Yeah, 6 month smiles.
Okay, so yeah, so Rick DePaul is 6 month braces. The other one's 6 month smiles.
Yeah.
Is there, someone's listening there, like, how did you pick between 6 month braces or 6 month smiles or Inman aligners, or any advice on picking an ortho starting point?
They actually all serve different purposes in different markets. I can only really speak for PowerProx because that's the one that I've actually looked into and bought and sat down and gone through the materials and learned from it personally. But first of all, they're not selling a system. They're not going to say, okay, here's what you can do with braces, but you need to use my lab and my wires and my brackets set up by my technicians. He teaches you how to think. He's not out to sell fancy tools or something that can only be used in a situation. He's teaching you how to look at a case, how to bring it through your brain. So he's actually selling orthodontic knowledge, and it teaches you how to approach cases, either simple cases or if you go on and do comprehensive cases later. The knowledge is all applicable. And Invisalign will teach you how to treat a case. It could be simple cases, complex cases. It's basically just another tool.
Invisalign.
Yeah, Invisalign. The Inman aligner gives you a good option for very, very limited correction cases, but sometimes if all the patient really wants is to just get that tooth moved in, that could be a good option if they don't want to have fixed, and you find it's a little bit more economical than sending it off to the Invisalign lab. So they all serve different roles and purposes. Yeah, and the Implant aligner, that's also something that's been gaining traction on Dentaltown. I see Donald Inman. He runs a lab in the U.S. Tiff from London. Inman's getting pretty big there.
So Inman aligners is from Donald Inman, in where?
Somewhere in the U.S. Yeah, he owns a lab.
So one of the things that's so neat about dentistry is yesterday I was talking to some graduates 1 year out of school, and I said, what's got you excited? And they said that their whole career they're not going to be sitting at a desk doing the same job over and over. They're not going to be in an assembly line doing the same thing over. That dentistry is, there's always something new, there's always something to learn, and it's just amazing how you can be out 10, 20, 30 years and there's just always so much more to know. So, what advice do you give to someone who might feel overwhelmed and they're sitting there saying, you know, Jonathan, I can't learn to place implants and do ortho and learn that CEREC machine. I mean, I can't. There's not enough hours in the day. Plus, I'm married and I got a 3-year-old at home. What do you say to that person who's feeling overwhelmed with so much to learn that it's almost suffocating?
Pick one thing. Sometimes the best way to approach a complex problem is to reduce it. You got to reduce it into different parts, reduce it into different steps. So, I mean, no one said you have to tackle every single discipline simultaneously. You know, it's like my earliest hands-on CE courses were on endo, and from there I did move on to implants, and I'm going to be starting up comprehensive ortho this year. So you can.
Who you gonna do that with?
There's some instructors coming down from NYU. They're also with DSS. Yeah, so they'll be running a course quarterly, sort of like a continuum thing. Every 3 months they do a module, a couple of days.
With Tommy and Andy Poe and Tommy Ng.
Oh yeah.
Am I pronouncing his name's Tommy NG, but NG is just Ng?
Yeah.
Am I doing it right?
Oh yeah.
So they're gonna set up. So DSS is gonna set up a quarterly ortho program. What, 4 times a year for what? 2 years?
For 1 year. It's a 1-year course.
So how long is each course? Like 3 days or?
3 days, yeah. Singapore people, DSS, orthodontics.
That's awesome. So what else? So you started you cut your teeth on endo. That was one of your earliest things you did.
Yeah.
Said? And how's endo? Is that still a part of your practice?
Totally. Just now during the talk that you were giving just now, you said that you know how pain is it's like the fun part of your practice, right? Pain's a major part of general practice work. At the end of the day, sadly, a lot of the reason why people come to us is because they're in pain. So endo is one of the major ways in which you're going to deal with pain. I'd say, you know, probably 80% of the pain that comes in has something to do with a lesion of endodontic origin.
So, Jonathan, help me with here, because in a country like America, the insurance pays 80% of the root canal. It's $1,000, and the insurance pays $800. It almost never gets denied. Like a lot of cosmetic stuff gets denied, a lot of implants gets denied, but root canals don't get denied. Dentists say they don't like to sell dentistry. When someone's in pain, they're begging you to fix it. But we continue to see that no matter if we go to the United States, Singapore, Australia, whatever, half the dentists hate molar endo. What advice would you give to someone who says, Jonathan, I graduated $350,000 in debt. I don't like selling dentistry. I get these toothaches. It's easy money. I mean, it's an easy sell. I mean, they're there. They're in pain. I could make $1,000, dude. I hate it. What any advice? I mean, if you're 30 years old and you hate endo, is that just kind of you're just gonna hate endo? I mean, have you ever seen anything to where someone hated endo at one phase of their life and eventually learned to love it? I mean, can you go from hating endo to loving it?
I could actually quote a real life example. There's a dentist who just got active on the board again by the name of Scott Perkins.
Scott Perkins. I love
Perkins.
Scott out of Houston.
Yeah, so his story was this. He's a very interesting man. He's very intense, and he has chosen, you know, as pretty much part of his life's mission to find ways to do things just more efficiently, you know. So he would take a crown prep appointment, and people would be saying, "Oh, I take an hour to do that," and you know, he'd find ways to just make it flow, you know, and cut it down to 15 minutes or something. And he tackled crown preps first, and the next thing he turned his eye to was endo. And he felt that he kind of hated endo as well. But he resolved that he didn't want to hate endo, so he pumped time into it. He basically conquered his dislike by beating it to death. So he would take extracted teeth and he would just practice how to get down the canals, how to find the canals. He would find the little tips and tricks that the instructors in school weren't telling him, that the textbooks weren't telling him. He was understanding about the layout of the teeth, you know. And that helped him out. I would say that half the time when we're working, the reason that we feel stuck is because we're just not familiar with something, and we have to stare at it for a few seconds, put down our handpiece, and go, what do I do now? And that feeling of being lost can be overcome in two ways. The first way is that you just practice enough times until it's gone. The second way is to leverage on the experience of others, which is once again where Dentaltown comes in, because you see all these cases that other people are posting. It's like being over their shoulder sometimes, especially when the photos are really clear. And you get into their brains because they're just typing out, okay, how did I approach this, and you can ask them questions. And you start to understand, how they come to decisions. And, when you've seen something the first time, and you see it again live, you're not so scared. Like when I got my first hex broken off of an abutment, because I'd seen about 2 separate cases on Dentaltown. I didn't crap myself. I got it out without destroying the implant.
Yeah.
Yeah.
So another time I feel really overwhelmed is when I bought a CBCT X-ray machine from Carestream, and you look at some of these images, and you're just like, what the hell am I looking at? I mean, I sit in my office with 2 associates and a dentist visiting from up the street, and there's 4 dentists looking at a monitor, and 4 guys are like one specific thing. You're like, what is that? And there's 4 doctors of dental surgery looking at it saying, I have no idea. Do you have access to a CBCT, or did you buy one, or what?
Yeah, the weekend practice has one.
And what do you think of the CBCT?
CBCT, it's got its place, definitely. I mean, you got to understand the strengths and weaknesses of a CBCT. The wonderful thing about a cone beam, measurement of length in hard tissue. So, you want to know the distance from the crest of the bone up to the floor of the sinus or away from the inferior dental nerve. That's going to be great for you. You want to see how wide that ridge is. It's great. Where it's not so strong currently is things like soft tissue. Because of the way that the cone beam technology works, it's basically they spin the beam around. They have a really complicated computer program to just piece everything together. It doesn't do so well with soft tissue. It can't tell you what kind of a soft tissue you have. There's a good soft tissue, or a crappy soft tissue. It doesn't tell you things about bone density. With the old fan beam CT scans, they will be talking about things like Hounsfield units, and that's roughly what the bone density is there. You can't do that with a cone beam. The other thing that it doesn't do so well is when you have a lot of radiodense objects crammed into a certain area, all right? Because when they reconstruct, you lose data in those areas. So you may be able to measure lengths, but if you're trying to look at things like, is that a crack in the tooth? It may not be. It may not actually be the most reliable. I remember some of the board members getting on a debate about that and saying that it's actually pretty terrible for cracks. On the other hand, if you want to see is that root canal infection going to the sinus, it's boss for that.
It's boss for that. I love it. So what else? We talked about so many subjects. Well, any other areas got you excited? Do you like pediatric dentistry?
Unfortunately not.
Yeah.
Yeah, that was also something that I picked up from Dentaltown. Sometimes certain things you just find that you're just really not good at it no matter how you try, and sometimes you want to put in the effort to overcome it, sometimes you don't, and I just found that I wasn't getting any joy in that one, and I didn't feel like it was a growth area of my practice. So I think it was 2 years ago I gave myself a Christmas present and I said no new kids under the age of 12.
Really? I've always thought that if some kids coming out of dental school with $350,000 in student loans, if they love kids, they got an ace in their back pocket, because that is one market that is always seems to be no one really wants to go after. I want to ask you another thing about Asia versus around the world, the cosmetic smile. Some countries you go to, like maybe England and Germany, the dentist will tell you that the people there think the bleached out American white teeth and veneers and the B1 shades just look like a clown, and they like more natural. Where does Southeast Asia and Singapore sit with tooth whitening? I mean, do they think the Hollywood smile on Lady Gaga is just too white, or are they born in natural? What is it like out here?
It can swing either way, actually. I mean, we usually try to go for a happy middle ground. Just go for A1. You know, no need to
A1?
no need to choose between refrigerator and toilet bowl. So, yeah. So on the other hand, yeah, I always try to tell my patients, try not to bleach the teeth whiter than the whites of your eyes. Otherwise, they look like they're gonna jump out and grab you in the face. Yeah.
That's good. I've never heard of that one. Your teeth should not be whiter than the white of
Whites
your eyes. So does that mean I got to quit drinking, or do I got to whiten my teeth?
Maybe you could find a way to whiten your eyes, man.
That's an old jaundice joke. It did jaundice yellow your eyes from drinking,
Yeah.
So would you say in general Singapore is less? They don't have they don't use so much the bleaching shades.
Yeah, less. We're still seeing patients who they're just really gunning for basic stuff. So they wanna have a slightly wider smile. Maybe they're more interested in the take home than the in office, or they just want the fillings to match and the crowns to match the natural dentition, which is kind of around an A2 to A1 anyway. Which is, to them, they're pretty happy with it.
I want to ask you a true false questions. A lot of times there's common sayings and common knowledge. But a guy like me who's a journalist who's wrote a monthly column since 1994, I try to make sure I can find citations or something to support what I'm saying. You just hear people off the cuff say that Asians smoke more and have more gum disease. And then you try to look at the data, and if someone says, compared to the United States, if someone said, do Asians smoke more and have more gum disease, how would you answer that?
They don't smoke more here. Cause smoking,
in Singapore?
Yeah, because smoking's mad expensive.
Smoking is mad expensive?
Yeah.
What about south of you in Indonesia or north of you in Malaysia?
It's
or
a lot
China?
cheaper there, so the smoking rate's way higher.
Your observation is that the price of cigarettes really affects the smoking rate.
Yeah, I think it was 2003. The health ministry made a decision to raise the tax on it, if I recall correctly. And they used to be able to sell small boxes of cigarettes and big boxes of cigarettes. So the small box was 10 and the big box was 20, and they banned the small boxes. I actually think they should have banned the big box, because finishing a box is kind of like a mental barrier for the patient to say, hey, stop it. But now...
So they banned the pack,
the little box.
The pack, you mean a pack of 20?
They banned the pack of 10. Now they can only buy 20s.
Okay, so they banned the pack of 10, and now you can buy a pack of 20?
Only, yeah.
And in 2003, what did a pack of 20 cost before taxation, and what does it cost
It's
now?
probably about $8 a pack now. It's $10 is pretty average based on what I see in the supermarket.
One of the most billionaire mayors of all time was the mayor of New York City, Mayor Bloomberg. And he was a billionaire businessman, and that was his big thing, that he totally believed that the higher you tax the cigarettes, the less would smoke. And I did see a lot of economists saying, especially in ages of like 16 to 21, a kid's thinking, well, a pack of cigarettes is this much money. I could buy a hamburger, fry, and a Coke 3 times for that amount of money. And so they start thinking, hell, I'd rather have a pizza than a pack of cigarettes. So you think the raising the price of cigarettes has made Singapore smoke less than its neighbors in Indonesia or China?
Yeah, maybe the health ministry's been a bit more aggressive about it.
What about gum disease? There's a lot of people who believe that for some reason or another that there's more periodontal disease in China than the United States.
I think that's because it's not being diagnosed. The dental culture, let's say China, the dental culture is different from in the US, whereby it's become a regular thing that you're in there 6 months and then you're going to get a cleaning done. Over there, they believe that cleanings are painful and you only see the dentist when you're already having dental pain. And, you don't see the dentist otherwise, unless you're missing teeth and you want to put back teeth.
So it's the culture of not
It's
going
emergency-based.
It's emergency-based instead of
Emergency-based.
preventative-based.
Yeah.
So you think that's something you'll see? Have you seen in your decade of practicing that Singapore starting to go from more emergency-based to more preventative-based? Have you seen a migration?
It's still
there
a
over
mix,
time?
actually. I do have my regular patients. I've got them fixed up already, and they're in every 6 months. We get new patients coming in, say, oh, my last dentist moved away, and I'm looking for a new guy, and they've been maintained on 6 monthlies. But I also get the patients, for various reasons, they're just coming in when something hurts or gets wobbly or swollen.
Mm-hmm. So what? So I only got you for we've already done 50 minutes. I only got you for 10 more. Anything else that's got you a passion? Anything else you want to talk about? Any?
CAD/CAM dentistry.
Okay, let's hear.
Yeah, I was alluding just now to the big announcement from Sirona about how they've gotten the zirconia crowns out in 1 hour, and I think this is a rapidly changing field. CAD/CAM, it just encompasses so many things. The CAD part is really about how you're gonna take the prep and digitize it into a form whereby the lab technician can use it to work on it and design on it, possibly, even entirely digitally, and the manufacturer, Cerex are already, 30 years old, and they've started with a subtractive method where you got that block of ceramic and you drill it down. And I hear that there's buzz out about one company that's making a laser machine whereby you can take the block and you can laser it, and that's going to remove the limitations of how finely the drill on the machine can drill it. And 3D printing's coming up. I've heard that who those guys now, Valplast has actually found a way to print Valplast. And there's another company called Vertex. They're looking at printing denture bases. And I'm sure printed teeth will be coming out soon. They'll have all these aspects that are interesting. For me, the things I like about CAD/CAM is that it gives you a way in which, when you're taking that digital impression, you know what you're gonna get. So you don't get any nasty surprises. When you're taking those impressions, I'd say 99 times out of 10, it's gonna turn out fine. But sometimes you just miss that little thing, and then 2 days later you get the call. Doctor, you missed that margin. And you're like, okay, and hey, call him back in. So at least that way, you do know what you're gonna get, because you do know what the lab technician's gonna get. So of course you can't take a crappy prep and expect that the lab technician's gonna just turn that thing into something wonderful. It's still gonna have the limitations of your prep, but at least you captured everything.
So do you think that was a big part of the Dentsply Sirona merger, because Dentsply was kind of a yesterday company that had all the impression materials and film x-rays and all the consumables, and then Sirona was the all digital play with CAD/CAM and CBCT and Galileos, and that it was kind of a merger where now Sirona would have a consumable like a block for their CAD/CAM machine, and then Dentsply would have a future as the world goes from all consumables to all digital.
Entirely possible, yeah, because Dentsply's got a relatively new block out called Celtra Duo, and I've been hearing good things about it. Hasn't come to my end of the world, but the Australians seem to be loving it. And Sirona's just gonna grow. It's like the Apple of CAD/CAM. They've got this whole environment here where they can take you from the start to the end using all their stuff, and it all just meshes so nicely. It's not just the hardware aspects, but the software itself. It just flows. Even that recent announcement with the zirconia, they had basically a closed environment. The camera is talking with the computer, it's talking with the milling machine, it's even talking with the oven. You just need to press the go button and make sure you don't have your finger in there when the lid closes.
So that was interesting. So if I said to you, of all the companies in dentistry, which company is the Apple company in dentistry? What company would you say it was?
Probably Sirona.
Yeah. I think you kind of alluded to that. You kind of said that. I just felt I never heard that before. So CAD/CAM has got you pretty excited.
Oh, yeah.
And what was the name of the block from Dentsply that the Australians like?
Celtra Duo.
Spell that.
CELTRADUO. 2 words.
Celtra Duo. And is that what is the material of that block?
It's lithium silicate, not disilicate, but silicate. So it comes in the color that it's meant to be, and you mill it. All right, and it can either be cemented then. It's going to be pretty similar to, let's say, your old style Sirona blocks or Vita Mark II. But if you fire it, all right, then it jumps to pretty much slightly tougher than lithium disilicate Emax, and because it's the color that it's going to be already, so staining's a little bit less intimidating than trying to work with a purple thing, right? And I hear that the milling times are shorter, and I hear that the fineness of the milling is really nice.
Right on. So anything else you want to talk about, or anything else got your fancy?
Other stuff. Well, it's just going to be interesting to see where the CAD/CAM market grows. It's even growing into areas like, you know, just simply replacing impressions, and you get to email the things to the lab. I'm fortunate because my company, you know, the group practice that I work with also distributes 3-shape scanners. So I have a 3-shape machine to play with at both the places that I work with, and we also get to see like the new materials evolving. You know, we've gone from the lucite reinforced blocks all the way to Emax, and I think some of the older CEREC users were saying how Emax just revitalized everything, and now zirconia is on the market. So that's all just great stuff.
So talk more about 3Shape. A lot of people have heard that it's a company out of Denmark. What is 3Shape out of Denmark? What are they doing in dentistry?
3Shape was interesting because apparently they got their start in making hearing aids. And somehow one of them had the idea, hey, you know, there's a whole market here. All right, dental stuff. All right, we're going to go to the labs first. We're going to have a way in which they're going to be able to use the computer and design in the computer rather than using their hands. All right, so that they can make the materials through computer design and then either mill them or 3D print them or somehow make them out and translate them into reality. So it's actually an entire ecosystem in and of itself as well, except that it's an open platform. You can send things from a 3Shape program to another program that's also open platform. You can send things from other programs in as well. So you're not locked down by a particular scanner. For example, someone using E4D, the plan scanner, can send to a 3Shape lab. A 3Shape lab can communicate with a Roland mill. You know, and it's good stuff. They've got modules in the lab end for crowns, implants, scan bodies. I scan my MegaGen implants. They've got modules for dentures, ortho. So it's turning into a whole big area by itself. At this point, I mean, they've already put themselves pretty tight in the lab market. They're one of the major manufacturers for computer design software on the lab end, and now they're starting to move into clinical as well with intraoral scanners. So their latest scanner, the Trios 3, it's pretty much an Omnicam competitor. Crazy fast imaging, you know, great detail capture.
You're a plethora of information. You're a walking, talking dental Wikipedia. I could listen to you forever. Well, that's our time, and I just want to tell you that, seriously, any advice for me on what could Dentaltown do to get more dentists from Singapore? What do you have, about 1,500 dentists here? And English is the official language?
English is the official language.
Everyone here in this country knows English better than any country in Asia outside of Australia, Auckland. I mean, I find more fluent English here than in Hong Kong. Do you?
Haven't been to Hong Kong.
I mean, it's just. I mean, like Indonesia, it's very tough. I mean, Indonesia, most people don't have any idea what you're saying. So if everybody here is in English, how can we get more of the 1,500 Singapore dentists on Dentaltown?
Well, I would say the first step is to get them on. Advertising. There's a big conference coming up in a couple of months. IDEM. That's like basically a major conference. They have a lot of they bring in speakers. They have a trade fair. It's in April. You guys had a booth 2 years ago, actually.
Yep, we did.
Yep, met Kerry.
Yep.
It says something when you can recognize somebody from the back of their head by their hair. Kerry. Yeah, and you know, push it at the trade fair. That's going to get people on already, you know.
Is that mostly dentists from Singapore, or is that from all the
regional? It's regional.
Very
so we get people flying in from Australia, we get people flying in from Indonesia, we get people busing in from Malaysia, you know. So it's good. It's regional, you know. And
can you email me the information on that?
Yeah.
Okay.
Yeah, and you know, hopefully you can convert a few from you know, just lurkers into posters, and you know, maybe some of them will be as loquacious as me.
Okay, so that's in April.
April.
I wonder if it conflicts with the Townie meeting.
I would need to check.
Have you ever gone to the Townie meeting?
Unfortunately, not.
Huh. So I'll go to the Singapore one if you go to the Townie meeting. Okay, so you've never been to the Townie meeting?
I haven't.
Well, I need to get you to the Townie meeting. I'll figure a way to do that. Okay, well, hey, seriously, that's an hour. Jonathan, thank you so much for all that you've done for dentistry with your own patients. Thank you so much for all you've done for Dental Town with your 3,600 amazing posts. You are so, you know so much about so much. I had an absolute honor and pleasure talking to you for an hour.
Thank you for Dental Town. It's given me so much.
All right, thank you, buddy. All right, bye-bye.